Two aspects that have made COVID-19 such a challenge for doctors are that it's indiscriminate and it's unpredictable. And that's a massive challenge, especially in big cities like Paris, where the region has over 12 million people. As time is passing by, more data is becoming available, and the medical community is exploring how to identify patterns in that data that's undetectable to the human eye in order to better understand and predict how the virus will evolve. I'm going to speak with two different experts, one here in France and the other in the UK, to get a better sense of how all this works. Professor Marie Pierre Revel, whom I'm about to go and talk to, is using 3D images here at the Cochin Hospital in southern Paris to build a vast database from 10,000 CT chest scans of suspected COVID-19 patients to help better understand the way that patients respond and the severity of the disease. Professor Marie Pierre Revel, it's a pleasure to meet you. What inspires you to do this research every day? It's very intense. What
gave me the energy was a personal reason. I had a very, very close friend who had COVID-19 disease. He's been hospitalized in ICU on April 3, and he died on May 17. And I couldn't do nothing to help the situation. But what I could do was to build a project. We need to understand, we need to have all this data, and we need that it never happens again. This was my motivation. Why is the virus posing challenges in terms of its severity and its unpredictability? This is a very important question. Indeed, in the vast majority of patients, the disease course is not severe. There are symptoms which are unpleasant, like fever, headache, but it's not life-threatening. Some patients, 7 to 8 days after the onset of symptoms, will have severe evolution. And this, we need to be able to predict it. So now we better know some risk factors for this evolution. We know that advancing age, male gender, pre-existing diseases, for instance, hypertension, we know that it is a risk factor to have this severe outcome, which is not at the beginning of the disease, but usually after 7 to 10 days, I would say. What imaging are you using in order to build up the data? We are using computer tomography, CT, and we are combining 10,000 CT scans of patients having a swab result. So we want to have different applications, one being an automated way to diagnose the condition. So we need patients with the disease and patients without the disease. And then on the images, we are going to analyze the pneumonia itself, and this is on this image here. On the right-hand side, you can see it's not black. It's a sign of infection, of the viral infection. In the alveoli, the small lung structures, air is replaced by inflammation created by the virus. So the proportion of diseased lung is really key to predict severe evolution. I'm presenting with respiratory problems. You've taken my COVID-19 test, it's positive. What is it that you're looking at from this work that will allow you to assess very quickly how I'm doing and how severe I'm going to get? So we need now to take into account all these evolutions, and based on all these criteria that we've been analyzing, trying for new patients to predict the evolution. Because regarding treatments, for instance, there is no need to propose some medication to avoid a severe disease course to a patient who is very unlikely to develop a severe form of the disease, especially if, as we can suspect, if there are no enough medications for a massive number of patients, we will have to better select those who really need the medication. We must not forget that even though in Europe we are out of the big wave, there are other parts in the world where the pandemic is really tragic, with thousands of new cases every day. In the States, in Brazil, the situation is not under control. So our research hopefully will help these countries.
So now we've got a sense as to why COVID-19 is so challenging. Claire Bloomfield, who I'm going to talk to remotely, is an academic researcher leading a consortium based out of Oxford University in the UK. And Claire's going to help explain how artificial intelligence is being developed and the way that the technology is being used to predict severe respiratory distress.
Claire, I've been speaking to heads of departments of cardiothoracic specialities, specifically here in Paris. What they're very keen to do is build the data sets in order to be able to respond better to the disease, but also better assess the severity. How is AI doing that?
AI can help us mine that data in a way that humans otherwise couldn't. So it's looking for patterns or looking for insights that the clinicians recognise are there, but speeding up that process, or frankly identifying other patterns that you otherwise wouldn't have picked up. And it can do that, as you say, through having access to lots of data. And that can be on the images themselves, or it can be through a combination of all the many, many types of data that you collect about a patient as they come into an A&E department. Blood pressure, what their blood cells are looking like, their PO2 levels, so their oxygen levels, and combining that information to find new insights, but either combining it so you get new patterns, or looking at some of the images on the X-rays or CT scans that they're producing to see if you can see some correlation or link between how poorly somebody's going to do and how they present in terms of their imaging or their other clinical measures.
How do you zone in on the perfect data and the perfect algorithm?
Data certainly isn't perfect, particularly real world data. And one of the things is just looking at gathering what you can and then working with that and iterating through. In terms of what makes a good algorithm, that's where you need to hand them back to the clinicians and say, does this actually do what you need it to do? So real world evaluation, taking algorithms and handing them back to the doctors and saying, does this look like it's useful? If you're an expert and you're very, very good at spotting the disease in the lung, so the pneumonia symptoms and the way it presents, can the computer do it as good as you can do it? And the only way you can assess that by putting it back against the doctors.
Claire, really interesting insights. Thanks very much.